So,
You probably don't have this. You'll have this
have this.
and this.
I have this. We'll see how this goes. Well, good morning, everybody. It's wonderful to be here, and glad that you people at the end of your meeting have braved the elements to show up. Here are some disclosures. I've been involved in developing a lot of these RF devices, and just as a matter of setting context, there are basically four energy types, categorizations that we could talk about, but I'm going to talk to you about radiofrequency electricity today. And so here are the objectives. You've got them in your handout. And we're going to start with nomenclature, because the symptoms to me of people who don't really understand what's going on with electricity start with the words that they use. And so these are words that I'm sure you're using, have used, or hear used in your operating room. And what I'd like to do as part of this educational process is actually have you stop using any of them. And so, of course, we have to give you some words to replace them with. And the first is the unit that you have that generates electricity, well, originally designed by William Bovey, is not a Bovey. It's an electrosurgical generator. We can call it an ESU for electrosurgical unit. And we aren't cauterizing things. What we want to get you to think about is what is the tissue effect that you are trying to create for purposes of propagating this surgical procedure. So you're either going to vaporize, or you're going to linear vaporize, which is what cutting is. You may desiccate, coagulate. You may be trying to fulgurate. Those are the words we want to hear you use, because that's what you're going to try to do with this energy. We'll find out that all radiofrequency electrosurgery requires 2 electrodes. Now, I could talk to you about some exceptions, but for all intents and purposes, all require 2 electrodes. And those electrodes can either be active or they can be dispersive, and we'll try to get you to understand that. There's no grounding in what you do. There's no return electrode, and you'll find out why. And there's no such thing as monopolar energy or bipolar energy. Those are just incorrect terms. You have instruments that can be monopolar and instruments that can be bipolar, and we'll give you an understanding, hopefully, of what that means. So what is this RF electrosurgery? And really what we're doing is we're converting electromagnetic energy to kinetic energy, and then that kinetic energy is converted to thermal energy in the cell. We're not heating something and then passively transferring that heat. We're actually causing these events to occur within the cell. And then we can then control those to affect one of those tissue properties, desiccation, coagulation, vaporization, or fulguration, which is really a special kind of desiccation and coagulation. So it's not cautery. You say, well, what is cautery? Well, cautery is the passive transfer of heat. So if you light a match and you burn your finger, that is cautery. Or if you work on a farm and you heat a branding iron and transfer that heat to the skin of your steer, that is cautery. But that's not what we're doing in the operating room. So we want you to have a practical understanding of physics. There is a certain basic amount that you need to know to understand this. And these physical properties are part of that process. So we want you to understand the differences between current and voltage. What does impedance mean? And what about energy and power? Because power is really what you dial up on most of your generators, at least in the United States. I know in France that number is not usually dialed up on your generator. So current, the flow of electrons past a point in the circuit in any given time. Its units are in amperes, and we really refer to the, not an electron, but a great mass of electrons called a coulomb. You'll remember that. And then voltage is really critical, because this is the difference in electrical potential in 2 points on a circuit. You really need voltage for those electrons to move, and that's measured in volts. Impedance is the degree to which elements in a circuit present resistance to the flow of electrons. Okay, so the term resistance is really the term used in direct or constant polarity circuits, and impedance is what we use in alternating polarity circuits. Energy and power, I'll put them both up at the same time because they're related. Energy is the capacity of a force to do work, and it's measured in joules. And power is the work or energy per unit time. So power, what again is on most of the North American generator faces, is the product of voltage and current. And so that's measured in watts. So if you alter power, you may be altering either or both voltage and current. So let's try to understand these relationships. And first I'm going to show you a metaphor that really helps you understand part of it in the context of direct circuits or direct constant polarity circuits. So this is Ohm's law, and this is really the most important equation, and it's only one of two equations I'm going to give you. And that shows you that the current is directly proportional to the voltage and inversely proportional to the impedance. Okay? So if we take this water tower that Roger Odella, an electrical physicist, designed this metaphor, and if we take this water tower and we say, okay, if we open the spigot, we'll get water coming out of that spigot. So the height of that water tower, where that meniscus is, reflects the difference in electrical potential. So that's the voltage. The flow here is the current, and the width of this spigot is the impedance or the resistance. Now, if we wanted to get more flow, what would we do? Well, we would elevate the tower. And what does that like in surgery? Well, that means we would be increasing the voltage. And when we do that, we get greater flow or greater current. And if we encountered impedant tissue, or we wanted to reduce the amount of flow, we would narrow the spigot. So the spigot's narrowed down, and despite the voltage being the same, there is less flow. So you say, well, what does this matter? Well, when you encounter impedant tissue like fat, or tissue that's scarred, or tissue that's already been coagulated or desiccated, that tissue is far more impedant and will impede the flow of electrons. So let's look at a practical example. If we have this blood vessel going into the bowel and we desiccate that, we're going to increase the impedance in that vessel. If we then go and desiccate it up here, the impedance will prevent the current from going to the bowel, and it will go back through the vessel. But if we then desiccate it here, the impedance will cause the situation to favor the current going through the bowel, and this is one example of how you can get a bowel injury with a monopolar instrument now, a monopolar instrument. Now, remember I told you we're actually using alternating current. And what does alternating mean? It's alternating polarity. So this is another metaphor that we came up with. This is a tube filled with water, and there's a little wheel there that generates power. So if we tip that wheel one way, we'll tip the tube one way, we'll spin the wheel. If we tip it another way, we'll spin it. And we can go back and forth like this and end up creating output without any real movement of the water in a circuit fashion. So if we look here to try to understand the difference between constant polarity and alternating polarity, here is a standard battery like the one you have in your phone. There's always a positive and always a negative. They always stay positive, negative. But with alternating polarity circuits, they switch back and forth, back and forth, back and forth. Now I'll pull this into what this means for surgery momentarily. So what's an electrosurgical unit do? What does this thing do? Well, fundamentally what it does is it takes a wall output, which in North America is 60 hertz or 60 cycles per second, and converts it into a radio frequency output, which is typically around 500,000 per second. So 60 hertz to 500,000 hertz, or 500 kilohertz. That's on the AM dial of your car radio. That's on the far left. and this is the radio frequency. And so these generators also convert, in addition to this RF output, they also allow you to adjust wattage and indirectly voltage and control something we call the duty cycle. So all of the currently produced ESUs create what we call isolated circuits. So what you just saw in the video is an example of a ground referenced machine. Excuse me. And so this is, but we now are using isolated circuits. So with an isolated circuit, you have an electrode that you want to activate, and you have a dispersive electrode, and the patient is in between those. You focus your current with one, you disperse it with the other, but it's all in one circuit. So the ground reference circuits, there is no return, if you will. There is no other circuit. You have to use the ground. So both the patient and the machine have to be grounded. Well, guess what happens with this? You have to use enormous voltage to get through that ground to complete your circuit. Also, that type of circumstance allows the circuit to go all kinds of places, to physicians, to nurses, to beds, to electrodes on the abdomen or chest, and cause adverse events. So we really, since the 70s, have been using isolated circuits. Okay? So why RF? What does that mean? So this is the electromagnetic spectrum here in a cartoon fashion, and RF is down in this area right here. These tissue effects are controllable and predictable. The other thing people ask is, why don't I electrocute myself? Well, the reason is that these frequencies, the mechanisms for depolarization of nerves and muscles, don't even recognize that frequency. It's so fast that the calcium channels, et cetera, do not even recognize there's been a shift in polarity. And that's why this doesn't happen after about 100 kilohertz, But we function typically, as we mentioned, in the 500,000, it could be 300,000, 400,000, 500,000 hertz range. So let's go look at an imaginary oscilloscope. If we have a direct current, that oscilloscope will deflect one way, and that means that there is current flow one way. And that current flow really goes from negative to positive. That's just like our water tower analogy. But remember, that's not what we're using with radio frequency. We have an output that looks like this, reflecting our alternating polarity, back and forth, back and forth, back and forth. So really, if you think about it, if you're an electron or an ion, you're just going back and forth, back and forth, back and forth. You're not going in a circuit. It's more of an oscillation. So think of the current flow rather than flow. Think of it as an oscillating current. And here's another way just to tie these together. So we fill that up with fluid. We tip it one way. We tip it the other way, back and forth, with no net flow. That's different from the sort of racetrack concept and flow concept that you see with a direct current. So let's go back to our generator. Basically, there are two waveforms that you use. There's modifications of these waveforms, but there's two. The first, and in North America, it's usually the yellow button or the yellow part of the machine, and it is a low voltage output that you see there. The second is the so-called coagulation output, which is usually coded blue in North America, and it's a high voltage but modulated output, so that at the same wattage, there is less current but more voltage. Less current, more voltage. So if we blow this up a little bit, the output from the so-called cut, and notice I'm always saying so-called, because you're going to learn that that's the output you should use for almost everything you do. But the so-called cut is generally a sinusoidal waveform like that. It's on all the time and going at 500,000 cycles a second. So you say, well, what's blend? And blend is not cut plus coag. It might have been 100 years ago, but it really is not that now. What blend is a modulated version of the so-called cut or low voltage output. And all it does is it takes advantage of Ohm's law. So, for example, that is on about 50% of the time, right? So instead of a 100% cycle, it's on only half the time. So we call that a duty cycle of 50%. Well, what's going on there? Well, remember Ohm's law. If we cut down the current, we're going to have to increase the voltage at the same output. So blend gets you a higher voltage output, but you can set your coag at 0, and your blend settings will still kick in. So we call that the duty cycle. Now, if we now go to the high voltage, this is what happens. So now we're only on about 6% of the time with our duty cycle, and since we've dropped the current so much, the voltage has to go much higher. And this high voltage has a lot to do with the problems with using this output with respect to safety. It also has something to do with how it can be used effectively. But with respect to safety, and even with respect to the quality of a vessel seal, it has a lot to do with it. Now, all of your electrosurgery is bipolar, all of it, okay? What differentiates the systems is the location and the purpose of the second electrode, the location and the purpose of the second electrode. So if we look at monopolar instruments, we have our patient here, we have our dispersive electrode, that's an electrode. We have our active electrode, that's an electrode, it's bipolar. They're both connected to the machine. All of the patient is between the two electrodes. Now, if we go down to a bipolar system, or bipolar instruments, what we have is our patient, but both of our electrodes are in our hand instrument, both of them. So the two wires now go back to the generator, and so the only part of the patient that's in this circuit is that between the two electrodes. So right off the bat, there's a safety issue here that's far greater with bipolar than with monopolar instrumentation. Okay, so how do these instruments, how does radiofrequency electricity cause these effects in tissue? So if we think of our basic temperature of 37 as normal, up to 50, nothing much happens. But at 50, we will get cell death in about 6 minutes. And at 60, we'll get instant cell death. So most of our instrumentation, where we get this immediate feedback, be it visual or otherwise, is getting our tissue temperature to somewhere between 60 and 90, 60 and 95 degrees centigrade pretty instantaneously or quite quickly. And what happens is the processes of desiccation and coagulation that we'll talk about. If we rapidly get our cellular temperature up to 100 degrees, we will have a liquid-gas conversion. And of course, when we get a gas conversion, our volume goes up and we'll get cellular vaporization. And that's what you use for cutting. So let's look at it in a cartoon. If we have a direct current or a constant polarity circuit, same thing, our intracellular ions will migrate to the opposite pole, right? The pole that's opposite to their charge. But if we have an alternating polarity circuit, it's not coming up, there it is. If we have an alternating polarity circuit, I'm going to do this manually for some reason. Why is that doing that, guys? Yeah. There it is. So they go back and forth, they go back and forth, they go back and forth. So what happens when they're going back and forth, back and forth, back and forth? We get a conversion of this radio frequency energy to kinetic energy, and all those molecules start bumping into each other, and the first thing we start getting is an elevation in intracellular temperature. Okay? So that's fundamentally how this starts. Now, finally, I'm going to take you through how then do we use this to create these tissue effects. So we already talked about vaporization. So if we quickly get our temperature to more than 100 degrees centigrade, we will get this conversion and vaporization. The cell will just explode. What about these two? So if instead of getting us up to 100, we're in this 60 to 95 range. What happens is we do have elevated temperature, we damage our cellular membrane, we start to lose water. So we get a process of desiccation. Visually, this looks like shrinkage to you when you look at it on a tissue level. But also at a protein basis, what happens is with this temperature elevation, we get hydrothermal rupture of these hydrogen cross-links, and they reform into this amalgam once they cool. So they're heated, then cooled, and we get this amalgam. So we get these two processes are going on together, desiccation and coagulation. Well, how does that happen? Is it what comes out of the machine? No, it's what you used to do in your backyard as a kid. You focus or defocus the energy. So we take the sun's energy if we're a little kid, and we take a magnifying glass, and we take that energy, and we focus it on the piece of wood to carve the initials of our teacher, our girlfriend, or ourselves in the little piece of wood that we're working with. And because at focal point, we will get an effect. And that's what you're doing here. It's not setting some output, be it coag or cut. What it is, it's focusing. So we call this power density or current density, and it's the area of the electrode near to or in contact with the tissue. So if you take a blade of your monopolar instrument, and you take the side of it, take the same instrument and use the edge, okay? The edge will create a higher current density. So at the same output, the same low voltage output, one with high power density will get vaporization, one with medium power density will get coagulation. We don't change what's coming out of the machine. We don't change the button. We change how we focus the energy. So if we are going to cut, we can start by vaporizing tissue. If we want to desiccate, we take the same output and use a greater area in contact with our tissue. That's the difference. It's not the output. And you can do the same thing with the so-called blended outputs. This output, this high voltage output, is designed for fulguration. It's superficial desiccation. So really for cutting and vaporization, we're not in contact. For desiccation, coagulation, we are in contact. And for fulguration, we're probably best not in contact. So cutting, as we said, is linear vaporization. So you start, you vaporize, and then you extend that. That's what you're doing when you're cutting. And here's another example. If we bring our electrode to the tissue, we activate it. Remember the vaporization? We create a vapor envelope or a steam envelope, and then we stay within that envelope and cut through our tissue. Technically, we never make contact with the tissue. Now, this might be the most important piece. For optimal tissue desiccation and coagulation, including the formation of a sound vessel seal, you want to coaptively coagulate, we'll explain that, relatively slowly with low voltage continuous output, not high voltage. So if you want to take one thing home, you don't use the blue button to seal a vessel. You use the yellow button. That's for our North American people. So why? Well, here's what happens. If you bring that high voltage, modulated high voltage instrument to tissue, what happens? You get these little outputs, little discharges. And what are they doing? They're randomly almost creating these little superficial zones of coagulation. So they become highly impedant, and they're an insulator. They actually prevent coagulation deeper. Whereas if you use the continuous low voltage output, you'll get a continuous and broader and more homogeneous elevation of tissue temperature. So to summarize these, this is desiccation. And so we got two things. Look at it on a cellular level or a tissue level. We're basically losing water. And we get coagulation. That's the protein coagulation, the amalgam. And those two together really create the seal that we're looking for. So if we have a blood vessel like this, if we don't compress that blood vessel, we won't get a seal. In fact, we'll get a heat sink effect and think we've got a seal because we're just heating the outside of that vessel. So of course you have to compress the vessel, and when you do that, you'll not only prevent the heat sink, but you will allow the two sides of the vessel to coapt and allow those processes of desiccation and then coagulation to occur. We call this coaptive coagulation. We'll look at this two other ways. So that's a blood vessel we're seeing in the side. Okay, there's what happens with the so-called cutting current. All right, that's what you want. This is what happens when you use modulated high voltage. You get those little spots that we showed you. You guys know this because you've experienced it. All right? Then what happens is you don't really often coagulate the center. And then when you pull apart your tines, it pulls apart the vessel with it. And part of that is because you have heated the tissue so much, you've broken down the organic molecules into sugars. We call that Carmelization. So it sticks. And that's what happens when you use high voltage. And this is am I going to do, yeah, there we go. This is one that we made for Fuse, if I can find it, there we go. And it basically is showing you the same thing in an animated fashion, okay? Here's the high voltage, see the spot weld type of approach. And here's the low voltage, a little slower, but far more effective to create a seal. Keep going the wrong way. Finally, fulguration, from fulgare, for lightning. And sometimes we want to do this, right? So now we're arcing to our tissue. We're getting this superficial coagulation, which is good for small capillary bleeding or ooze. And so fulguration is basically high voltage modulated current, no touch, large surface area electrode. Those who use an argon beam coagulator are basically using fulguration, propagated by this very ionizable argon. So those are the things we wanted to get through with you. Understand nomenclature, have a practical understanding of physics, understand an electrosurgical generator, what it does, know the mechanisms whereby this energy causes a tissue effect, and understand these differences between vaporization, cutting, and desiccation coagulation. Thank you very much.